Professor Sutee is he's the Emeritus Professor of Pathobiology and Consultant of Center for Vaccine Development, Institute of Molecular Biosciences, Mahidol University, Thailand. And Professor Sutee will present on breakthrough approach on dengue vaccination amid COVID-19 pandemic. So please, Professor Sutee, so please go on.
Thank you very much, Professor Usa, for inviting me and including ADVA, and then welcome all other scientists around Asia and even in Latin or other part of the globe. Can you hear me well? Yeah. Can you hear me?
Please go on very well. Go on, please.
Okay. My assignment is to breakthrough approach of dengue vaccination amid COVID-19 pandemic. So this means that we have to move dengue vaccination, even though we have a lot of problem about COVID-19. My assignment, I have been working with dengue vaccine for 4 decades. And then, however, to make the story short, since the end of the 2015, the first dengue vaccine, a live attenuated vaccine, Dengue from Sanofi, has been licensed in several countries around Asia or even in Latins. And then trials on Dengue indicate that those with pre-existing dengue seropositive demonstrated favorable response to this vaccine, even though they are their seronegative counterpart. Then, for my presentation, what is the breakthrough? What should we do during this COVID-19 pandemic? According to the publication from WHO, we in the year 2017, WHO launched a guideline for dengue sero survey, and then with this we could follow the instruction or guidelines. My first part of the report to you, share the information with you, is that for public approach, determine dengue sero prevalence among those who are around 2 to 60 years of age. Information obtained from this study may be useful in predicting the value of the population of dengue infection and potential impact of dengue in children and adults. And the second part, for individual approach, establishment of reference sera panels for rapid dengue test, RDT evaluation. Then, with the first approach and the second objective, the second objective should give some information to the audience of this scientific meeting that how should we do, how should we accelerate the program. For dengue sero survey in Thailand, the Ministry of Public Health started doing that in the year 2019. And then, however, we did sero survey, sero prevalence of dengue virus in healthcare workers at the Queen Sirkit Institute of Child Health, Bangkok. A total number of subjects were included, 400 subjects altogether. And then later on, during the epidemic or pandemic of COVID, we did study in children and adults. The Department of Disease Control, MOPH, conducted seroprevalence of dengue among Thais aged 2 to 60 years of age. There were a total of number of more than 1,200 subjects were included in the study. So, in conclusion from this slide, previously, 5 or 6 years ago, we did seroprevalence of dengue in adults in Bangkok. However, later on to expand the scientific data of seroprevalence, we expand to younger age group, started from 2 years of age. For the seroprevalence in adults, we found that in the width bar chart, started from 2 to 21 years of age. It was found that we came across more than 80% of seroprevalence of dengue in this age group. And then at the age of 51 to 60 years of age, almost 100% of them experience to dengue. What does it mean? This means that seroprevalence of dengue from the adults started very early. And then if you do perform seroprevalence of dengue in 21 years of age up, then a proportion of adults with seropositive for each dengue serotype then will increase after in the old age. And interestingly, we found that amount of if you use ELISA IgG, immunoglobulin IgG, then at the older age, the OD ratio will increase. What does it mean? Probably it means that there are several rounds of reinfection and then natural booster. From this seroprevalence in adults, I would say that conclude that 7.54 of Thai adults revealed naive to dengue, and then 7.14% revealed partial immune to dengue. Around more than 85% had already been infected with all 4 serotypes. Then from our study, in this study, 252 subjects, only 19 of them naive to dengue all 4 serotypes. And then for the partial immune subjects, partial immune means 1 immediate immune to dengue, 1 serotype or 2 or 3 serotype. And then around a same percentage of them reveal partial immune. And then another the same figure was true for their naive subjects. And then, as I mentioned, around 58% of them, 85% of them immune to all 4 dengue. Now, let's move. For this, we could conclude that small percentage of adults in this setting remained at risk for symptomatic dengue infection. What does it mean? It means that we have to, in order to, they have the risk to be severe, to be suffer from severe dengue infection, dengue hemorrhagic fever or dengue shock syndrome or others. So whether we should immunize in those adult from to senile of age, we have to consider. Probably they have to subjected to screening by using RDT, the reliable one. So now let's come back to the target age group that we have to immunize, we have to pay attention. From my peer-reviewed data that we try to analyze using 682 subjects in the younger age group, age range from 2 to 20 years of age or 19 years of age. The number of around 71 to 146. If we classify by using ELISA IgG OD ratio from small number, low, less than 2 OD ratio, and then moderate or high, or medium or high. Then in the younger age group, around 61% of them reveal negative. This has been standardized and then try to correlate with NT, the gold standard. And then we should rely on that. If less than 2.0, then they revealed this for each age group, revealed 61% naive, 56, and then 30, and then 20. By the age of 20, around 28 of them, 20% of them reveal negative to dengue. However, if we classify by using OD ratio more than 4.01, then the number will increase from young age group 2 to 5 to 60% in the age group of 15 to 19 years of age. So if we look at this group of people at the very young age group until 19 years of age, people could classify which age group that we should immunize. Then the zero preference, 70% should be around which area to make the benefit of this. And then I could conclude from this one that the previous slide, that zero prevalence of dengue from the age of 2 years up till 60 years had been done in Thailand. And then we are going to report this and publish that later on by the Ministry of Public Health, my friend over there, and including my laboratory people. Then the next question is, can we apply this into the field? We cannot use plaque reduction neutralization test. Is there any advice to use? People, a lot of us have been familiar with RDT, rapid dengue test. Then, however, in order to do that in each country, at country level, we have to have a panel. And then in this slide, table 3, we have to propose establishment of well-characterized panel for RDT. Then this is I have divided it into 7 categories, serial number 1 until serial number 7, and then serial characteristic like this. The first column or the first row will be dengue negative, and then followed by and then JE negative, and then we have to come up to that number, and then the second number group should be dengue negative and then JE, in order to find any interference, JEV interference. And the third group should be dengue negative and JE positive by vaccination or by natural. Okay, that number should propose to be like this. And then the fourth category, dengue positive, partial immune. This is the most important part, whether we should identify group of people, a group of their population in that certain area, whether that RDT should detect partial immune subject. And then for dengue, probably they might consider to start from this group. So we increase number to 90. And then for those who reveal dengue positive to all 4 serotypes, that's certain number. And then for the last two group, the number 6 and number 7, dengue negative, and then positive interference by other virus like Zika, chikungunya, or even COVID19, as a lot of us have mentioned about that. And then 7, the last would be dengue patient. This remember, this is to for zero survey. So is there any interference from dengue patient? This had to be included. So the total number should probably come up to be 360. And then probably ADVA could help to accelerate this kind of activity or connection network between the laboratory that have that this kind of panel, and then collaborate with the at the other national level, at the other countries at national level. So in summary, at public level, population-based zero prevalence study are the best way to measure past infection with dengue virus. A country might consider to invest and make decision on where a dengue vaccination might be useful. And then at individual level, yesterday we have listened to how we should do that at the clinic or even at the hospital bed. Pre-existing immunity could be identified using suitable RDT. Availability of well-balanced, well-characterized panels are crucial for success of the evaluation process, as I mentioned a moment ago. And then I would like to acknowledge by the Department of Disease Control of the Thai MOPH and the Queen's Synergies Institute, Dr. Vanderpit, and by staff at the Center for Vaccine Development, and then this work or research activity was supported by the NVI of Thailand. Yeah, thank you very much.